Hey everyone, welcome back to my channel Dental Cafe. So today we are going to discuss about the mandible and its anatomy and its clinical significance at the time of surgery and at the time of prosthesis fabrication. Okay then, let's begin the video. So this is we have a lower jaw as you can see in the video. This is we have a mandible and it is the largest and the strongest bone in the human skull that forming the lower jaw and holding the lower teeth. As you can see, it's a U-shaped bone. So remember, it's the largest and the strongest bone. So today we are going to discuss about the mandibular anatomy, which is very important before doing any surgical procedure and its clinical importance. So begin with the anatomical part. So this is we have a symphysis region in the center of the mandible where two half of the mandible meets. So, what is symphysis? It is a midline fusion point of two half of the mandible after birth. Then we have parasymphysis of mandible on both the side of symphysis region located between the roots of the canine teeth and the central incisor and also referred to as a part of chin. Now the clinical significance of symphysis and the parasymphysis. As you can see in the middle, this is we have a symphysis. It's a palpable vertical ridge as it has a little vertical protuberance. So we can palpate it. Then in orthodontic diagnosis, its shape, size and inclination of symphysis provide the information for diagnosis and planning of the orthodontic treatments. And it is very important for the lower incisor positioning in the denture. Now parasymphysis. As you can see in red, both the side of the symphysis we have a parasymphysis. It forms chin part and it is very important for the facial aesthetic. Fracture of symphysis and parasymphysis affect the facial aesthetic, so it is very important. Symphysis and parasymphysis fracture are very common due to direct impact because they are more prominent parts. So direct impact can lead to the fracture of symphysis and parasymphysis, which will result in lower jaw narrowing and malocclusion of the anterior region of the jaw. Now, other anatomical landmark on the outer structure of the mandible is, as we have already discussed about the parasymphysis and the symphysis, now we have a body of the mandible. Now, this marked area is the body of the mandible. It begins from the parasymphysis region and end at the angle of the mandible. Then we have a angle of the mandible, and then last we have a ramus of the mandible. And ramus of the mandible have two projection. One is coronoid process and other is the condylar process. We'll discuss about them in later video. Now the clinical significance of each parts. This is in red. We have a body of the mandible. Superiorly, it have an alveolar border which have sockets and the 16 lower teeth. Then inferior base, we have a digastric muscle attachment. Now this is we have an angle, the corner of the jawbone where vertical ramus meets the horizontal body, and it is very important because it is the attachment point for muscle of mastication. Very important. Then we have a ramus of the mandible. It is vertical and posterior portion of the lower jaw and extend upward from the lateral part of the each side of the jaw. And it has two projection. First one is coronoid and the other one is the condylar. We'll talk about the condylar process later on. And as you can see in the figure, coronoid process, it is a triangular projection and it has a muscle attachment that is temporalis muscle. As you can see in this figure, we have a condylar process. The most posterior part of the ramus which articulates with the temporal bone to form the TMJ. And we have a neck of the condyle. Then we have a sigmoid notch. It is U-shaped and it separates the coronoid process from the condylar process. Now the clinical importance. We have a condylar process is articulate with the temporal bone to form the temporomandibular joint, and this joint is very important. And this is U-shaped concavity on the superior border of the mandibular ramus is the sigmoid notch, and it separates the condyle from the coronoid process. Now structures present on the inner surface of the mandible. On internal surface, this is we have a mandibular foramen, and mandibular foramen is present on both the half of the mandible. And then this is U-shaped. We have a lingula on the both the side of the mandible, and from lingula there is mylohyoid ridge begin towards the base, and then we have both the coronoid process and both the condylar process on the inner side of the mandible. And here in the center of the internal side of mandible, we have a genial tubercle. In red color area, this is we have a mandibular foramen. About the mandibular foramen, we'll discuss later. Then in pink marked area, this is we have a lingula. It is a tongue shaped projection of bone on inner side of the mandibular ramus, and it is near the mandibular foramen. It is important landmark for oral and maxillofacial surgeon because it is in close proximity to the mandibular foramen through which inferior alveolar nerve and vessel passes. So it is of great importance for oral and maxillofacial surgeon. Then spine of the lingula having sphenomandibular ligament attachment, as you can see in the figure. Both the side we have a sphenomandibular ligament attachment. Then on both the side we have a bony crest area which is called mylohyoid line or the ridge. It extends from the third molar to the symphysis, and it is very important attachment for the mylohyoid muscle, and its importance is in prosthetic planning. How? Due to resorption in old age, it becomes sharp and may causes pain and discomfort for the patient who is wearing lower denture. So denture should be required adjustment, adjusting the lingual flange so that pressure on the ridge is not applied and it will not cause any pain. Otherwise, patient always complains of pain on the inner side of the denture if the mylohyoid ridge is sharp. Now the foramen present on the mandible, as you can see, this is we have a mandible. So basically we have two types of foramen. First one is the mental foramen, and second we have a mandibular foramen. Look at the video. This one, the one we are pointed with the green pointer, is the mental foramen present on the outer surface just below the second premolar. As you can see on the other side also we have mental foramen just below the second premolar, and the second one we have a mandibular foramen on the inner side of the mandible. As you can see in this video, both the side we have a mandibular foramen. So through mandibular foramen, inferior alveolar nerve and inferior alveolar artery passes, and it supplies teeth and the tissue of the lower jaw, as you can see in the video. And then from the mandibular foramen, it passes through the mental foramen, and mental foramen is the exit point for the inferior alveolar nerve, and from here it becomes mental nerve, and it supplies the chin area of the lower jaw, as you can see in the video. And both the nerves are very important for oral surgeon at the time of surgery. If we accidentally puncture these nerves, it may causes the numbness in the chin area or in the lower jaw region. Now the function of the mandible, first one is a mastication, as it allows the muscle of mastication attachment, so it's help in mastication because it is a movable bone. Then we have in speech, its mobility allow for the complex movement required for articulation and the speaking. Then facial expression, it serves as an attachment site for muscle involved in facial movement. Different muscle attachment of the mandible I'll tell you in the next video, and because of that muscle attachment, it have a major role in the mastication and the facial expression. I hope this video is helpful for you to understand about the anatomy of the mandible and its clinical importance. So don't forget to like, share and subscribe my YouTube channel and hit the bell icon for the latest video.